Assalamu alaikum. Today inshallah is going to be our last lab about the ECG. In today's lab we're going to discuss a number of ECG abnormalities. Of course, these ECG abnormalities result from an abnormality in the cardiac muscle. This abnormality will have an effect on the ECG, which can help us in the diagnosis. So the ECG can help us in the diagnosis of these cardiac abnormalities. Now, most of the abnormalities that we will talk about today are actually arrhythmias. Okay, and the term arrhythmia means an abnormal heart rhythm. Now, the abnormality might be in the rate or it might be in the regularity of the heartbeat. You know that the normal heart rate is between 60 to 100 beats per minute. So if the rate is less than 60 or more than 100, then it is abnormal. Also, the depolarization wave should always start in the SA node. It should spread to both atria. It should go into the AV node where it is delayed for a certain period of time. Then it should pass through the AV bundle into the ventricles, where it will enter the left and right bundle branches at almost the same time. So if anything disrupts this pathway, this will lead to an abnormal heart rhythm. So usually the cause of arrhythmia is some abnormality in the excitatory or conductive system of the heart. Okay? Now, the causes of arrhythmias are numerous. It might be due to an abnormal rhythmicity of the pacemaker. So the cause might be in the SA node itself. The cause of arrhythmia might be a shift of the pacemaker from the sinus node to another place in the heart. So sometimes if there's something wrong in the SA node, if it's not functioning normally, the pacemaker of the heart becomes another point of the excitatory system, and usually the AV node becomes the new pacemaker. But this will create an abnormal rhythm. Okay, an abnormality in the rate and an abnormality in the rhythm itself. Okay, the cause might be blocks at different points in the spread of the impulse through the heart. So if the AV node, the AV bundle, for example, is blocked, this will create an abnormal rhythm. If one of the bundles, the left or the right, is blocked, this will create also an abnormal rhythm. And we will talk about these conditions later on. Okay, it might be due to an abnormal pathway of impulse transmission. You know that usually the only pathway that transmits a signal from the atria to the ventricles is the AV node and the AV bundle. If there is an abnormal pathway that conducts the impulse between the atria and the ventricles, then this will create an abnormal rhythm. And finally, spontaneous generation of impulses in any point of the heart. If a certain part of the heart undergoes ischemia or infarction, or if it gets calcified, it might start generating impulses, and this will disrupt the normal cardiac rhythm. Okay, now, at first we're going to talk about sinus tachycardia. Now, the word tachycardia means a fast heart rate above 100 beats per minute. And when we say sinus tachycardia, it means that the rhythm starts in the SA node, but it is faster than normal. So the only abnormality here that we will see on the ECG strip is a fast heart rate. Okay, everything else is supposed to be normal because the signal starts in the SA node as it should, and it spreads in its normal pathway. The only problem here is that the firing rate of the SA node is higher than normal. Okay, this is seen normally in cases of physiological stress due to increased sympathetic activity, because you know the SA node is innervated by the sympathetic nerves. So if there is an increased sympathetic tone, this will increase the firing rate of the SA node. Now, When we say physiological stress, it might be due to emotional stress or physical stress, like exercising, for example. The emotional, like being angry, being stressed, this will increase the sympathetic tone and will consequently increase the heart rate. Now, there are other causes for sinus tachycardia, including fever, pain, dehydration, hypovolemia, anemia. All of these conditions might increase the heart rate. Now, if you look at this ECG strip, you will notice that everything looks normal regarding مثلا the presence of P waves, the duration and the amplitude of the P, the duration of the QRS, the presence of T waves, everything looks normal. But if you calculate the heart rate, okay, let's see the distance between two R waves, يعني it is almost 9 small squares. فممكن نحكي إنه الهارت rate عبارة عن 1500 divided by 9 small squares, and it is almost 170 beats per minute. So the heart rate, according to this strip, is about 170 beats per minute, which is obviously very high. Okay, so if you see an ECG strip where everything looks normal except for the fact that the heart rate is increased, then this is sinus tachycardia. Okay? طيب. The other condition is called sinus bradycardia. It is the exact opposite of sinus tachycardia. Here we have a slow heart rate below 60 beats per minute. The cause for this condition is decreased firing rate at the SA node. Usually the cause is increased parasympathetic tone. Okay. Now, if you look at this ECG strip, everything looks normal again. There is a P wave, QRS complex, T wave. Everything looks normal, but if you calculate the heart rate, if you take the distance between two R waves, 2, 3, 4, 5, 6, 7, it's gonna be almost around 40 beats per minute تقريبا in this strip. لو بدنا نحسب الهارت rate, it's gonna be around 40 beats per minute, which is obviously low. Now, since everything else here is normal, then this is sinus bradycardia. Okay? هلا sinus bradycardia, it can be a normal finding in athletes. هلا بتعرفوا إنه الأثليتس they have خلينا نحكي stronger hearts. And because of that, their hearts pump a large stroke volume with every beat. So if they are resting, and in order to maintain a normal cardiac output, their heart rate will drop. يعني معظم الأثليتس بيكون الهارت rate عندهم around 50-40 beats per minute at rest. لأنه at rest, their hearts are pumping a large stroke volume. And so to maintain a normal cardiac output, the only way to do that is by decreasing the heart rate. Okay, so it's not always, it doesn't always mean that there is something wrong. طيب, وحكينا إنه mostly هي جاية من خلينا نحكي parasympathetic stimulation. If we have an increased parasympathetic tone, this will lead to sinus bradycardia. Again, here you have to remember, and we say it is sinus because the depolarization wave starts as usual within the SA node and it spreads in its normal pathway, but the rate is decreased. Okay. We have another abnormality called sinus arrhythmia. Okay, sinus arrhythmia. Now you have to know that normally the heart rate increases with inspiration and decreases with expiration. This is normal, okay? But sometimes, especially in the young, healthy people, this variation in heart rate between inspiration and expiration is very large. The variation is very large. Okay, so this condition is called sinus arrhythmia. يعني هلا نحن most people will have a difference in their heart rate between inspiration and expiration, but usually the خلينا نحكي the variation بالRR interval does not exceed 0.12 seconds. Okay, does not exceed that between inspiration and expiration. If the deviation is more than this, then we call the condition sinus arrhythmia. Okay, and this condition is absolutely benign, يعني it doesn't need any treatment, and it's very common in the healthy young people. Okay, so again, it is sinus arrhythmia, sinus, so the rhythm starts in the sinus node as it should, but the effect of inspiration and expiration on the heart rate is very evident. Okay, واضح جدا إنه في تأثير واضح عليها. هلا هذا المثال هون هو مثال على الساينس arrhythmia. Of course, you can see that before every QRS complex we have a P wave. The PR interval is constant. Everything looks normal in this rhythm except the fact إنه ال RR interval has a lot of variation. Okay, a lot of variation. The variation exceeds 0.12 seconds. So this is sinus arrhythmia. This is how you know that this is sinus arrhythmia. Okay, so all of these conditions, sinus bradycardia, sinus tachycardia, and sinus arrhythmia, are abnormal sinus rhythms. So the rhythm starts in the SA node, but there is some abnormality. Either the rate is very high, very low, or very variable, extremely variable. Okay? Okay. Now we will talk about another condition called ventricular fibrillation. Before we discuss ventricular fibrillation, I'm gonna explain to you the phenomenon of re-entry. Okay? Okay. Okay. So this picture represents the ventricles, and I care about this one the most. This part of the picture represents the ventricles when they are completely depolarized. Okay, all the muscle mass is depolarized. Now, when all the muscle mass is depolarized, when the signal, the depolarization wave, reaches this part and depolarizes it, because this is the last part to depolarize, what happens to this cardiac impulse in the normal conditions? This impulse is gonna fade away. It's gonna die. Okay, why does that happen? Because all of the ventricular muscle mass is depolarized and it is still in the refractory period. So this impulse, which entered from the atria, which depolarized the septum and spread into the endocardial surfaces, then the epicardial surfaces, it now has no place to go. Okay, يعني هاي السيجنال هلا عملت stimulation لكل الكاردياك muscle tissue اللي موجود بالventricles. So it has no place to go. All of the cardiac muscle fibers are now in the refractory period. So this signal usually dies. It dies. Okay? Now, this is another figure which shows the same idea. Here we have a circular pathway. This is a circular pathway, and the impulse started here, the impulse of depolarization, and it started moving like this. Now, when it reaches the original point where it started, this point is still in the refractory period. So this signal is gonna die. Okay, it's gonna fade away. and this is important. Now, sometimes, for reasons that we will mention, this signal is not gonna die. It's gonna continue to stimulate the same muscle or the same group of muscles over and over, muscle fibers over and over again. And this phenomena is called the phenomena of re-entry. Re-entry. It means that this signal, when it reaches this point where it originally started, it can stimulate it again. And so it will go on and on for a long period of time. This is the phenomenon of re-entry. Okay? Now, what are the causes for this phenomenon? Why does it happen? The first condition that might lead to the occurrence of this phenomena is the fact that the pathway through which the signal has to travel is longer than usual, longer than normal. فإذا افترضنا مثلا إحنا إنه this is the heart, and the heart becomes dilated يعني كبر حجمه. This means إنه the signal will have to travel in a longer pathway than normal, which means إنه when it reaches the original point where it has started, this point will be out of the refractory period, so it can re-stimulate it now. Okay, so this is one reason why we have re-entry, if the pathway through which the signal travels is prolonged, is longer than normal. Okay, the other condition that might lead to the phenomenon of re-entry is decreased rate of conduction. يعني if the signal normally travels at a rate of مثلا 4 meters per millisecond, and then the rate decreased by half, this means when it reaches the original point where it started, this point might have gone out of the refractory period and can be re-stimulated. Okay, so decreased rate of conduction can lead to the phenomenon of re-entry. And the last thing that might lead to the occurrence of re-entry is a shortened refractory period. If the refractory period becomes shorter than normal, then even if the conduction speed is the same, even if the pathway is the same, this means that when the signal reaches the original place where it has started, it might lead to re-entry. Okay, فإذا أسباب re-entry يا إما إنه the pathway becomes prolonged, and this happens if the heart is dilated, for example, or if the rate of conduction is decreased. وهذا ممكن نشوفه إذا صار مثلا في عنا blockage بالبيركنجي system. إحنا طبعا هون عم نحكي عن ventricular fibrillation. So yeah, if there is a blockage, for example, in the Purkinje system, تعرفوا أنتوا Purkinje system, it fastens the rate of conduction. If there is a blockage, the rate of conduction might be decreased. Sometimes due to ischemia in the cardiac muscle, due to hyperkalemia. Hyperkalemia might lead also to decreased rate of conduction. الحالة الأخيرة اللي هي shortened refractory period, this might be due to the use of certain drugs. في بعض الأدوية زي الإبنفرين إذا كان المريض بياخدها، إذا كان الشخص بياخدها، هذا بيؤدي ل shortened refractory period، وبالتالي ممكن يؤدي لحدوث الفينومينا of re-entry. شو هي الفينومينا of re-entry؟ إنه السيجنال depolarization wave does not die out as it should. It continues to stimulate the cardiac muscle over and over again. Okay. هلا هاي الفينومينا of re-entry, it is dangerous because it can lead to ventricular fibrillation. Okay. هلا ventricular fibrillation is one of the most serious of all cardiac arrhythmias. Okay, this is a deadly form of cardiac arrhythmias. If it is not stopped within 1 to 3 minutes, it might lead to death. Okay? Now, what causes the ventricular fibrillation? اللي هي phenomenon of re-entry. يعني depolarization wave أو cardiac impulse does not die out. It continues to exist within the ventricular muscle. هلا اللي رح يصير خلينا نشوف إنه مثلا دخلت في عنا إحنا هون signal من الاتريا. This signal didn't die out. It found a certain part بالventricles. يعني هي after it spread normally it should die out. It didn't. It found a certain spot بالventricles that it can re-excite. So it re-excited this part. طبعا رح يرجع يدخل عنا إحنا signal مرة تانية من الاتريا. هاي signal it will excite also the ventricles and it will not die out. It will find another area بالventricles that it can excite. This will go on and on. فبالتالي نحن at the end we will have multiple excitation waves that are working within the ventricles. Okay. هلا خلينا نفترض نحن إنه كان في عنا مثلا this is a signal. It found a certain area that it cannot excite and another area that it can excite. So it goes here. بيجي عنا signal تانية from somewhere else. This area now has gone out of the refractory period. So it will excite this area. So each area is excited by a certain signal. So the excitation of the ventricles is not coordinated. The excitation of the ventricles is not coordinated. And so the pumping of blood is not coordinated. هلا احنا يفترض عشان ventricles they can pump enough blood into the arteries انه they should contract, the whole muscle should contract at the same time. Now, if every portion of the ventricles is stimulated by a different signal at a different time, this means that every part of the ventricles will contract on its own. This will lead to an effective pumping of blood by the ventricles. Okay? And this is what we call ventricular fibrillation. This is why it is deadly, because there is no effective pumping of blood. So within 1 to 3 minutes, the patient might die unless طبعا treated. هلا what might lead to ventricular fibrillation? It might be due to sudden electrical shock of the heart. It might be due to ischemia of the heart muscle or ischemia of the conducting system. Or it might be a result from other forms of arrhythmias. في عنا مثلا زي supraventricular tachycardia, it might after a while lead to ventricular fibrillation. Okay? هلا, what do we see on the ECG when we have ventricular fibrillation? Okay. Usually طبعا بيكون في عنا waves, but they are bizarre waves. يعني you cannot know if there is a P wave, a QRS, a T wave. No, you just have waves. They have different durations, they have different deflections, they have different voltages, but usually the voltage is around 0.5 millivolt. Okay? When the fibrillation first starts, بيكونوا الwaves تقريبا بحدود 0.5 millivolt. But later on, if it continues, رح تلاحظوا إنه الstrip بيصير almost like a flat line. Like this. Okay, يعني it's almost like a flat line. Okay, so ventricular fibrillation is one of the most dangerous types of arrhythmias. It should be treated immediately. The cause for ventricular fibrillation is re-entry, phenomenon of re-entry, and you should know how it looks on the ECG. Okay. Now, okay. Now we will discuss atrial fibrillation. Now the mechanism for atrial fibrillation, it's identical to that of the ventricular fibrillation. It is almost the same, but it happens in the atria, not in the ventricles. So it is the same. We have the phenomenon of re-entry, but it happens in the atria. Now, a frequent cause of atrial fibrillation is atrial enlargement, okay? And usually there is the source of the abnormal or the disorganized impulses usually starts at the roots of the pulmonary veins, okay? So here also we have a signal that has gone that doesn't die away, that doesn't fade away. وطبعا بده يصير عندنا more than one signal, and these signals will continue to divide and re-excite different parts of the atria. So this will lead to disorganized activation of the atria. Okay? هلا what we will see on the ECG strip هذا مهم. هلا اللي رح نشوفه إنه there are no definite P waves. ما في P waves لأنه ال P wave هي جاية من ال excitation of the atria، ويفترض إنه ال excitation لل right وال left atria it happens at almost at the same time ويعطينا ال P wave. فبما إنه ما في عنا coordinated excitation لل atria we will have no P waves. Simply إنه رح يكون ال baseline is wavy. Okay, ال baseline زي ما أنتم شايفين هون it is wavy, which means إنه في عنا continuous excitation بالاتريا، وهذا بيخلي اللاين اللي موجود بالاي سي جي ما يكون ايزو الكتريك. طيب هلا بالنسبه للكيو ار اس كومبلكسز رح يكونوا موجودين they are there. ممكن التي ويفز يكون صعب انه نميز وين هي موجوده لانه اصلا الامبليتيود لها بالعاده ما بيكون كتير عالي مش زي الكيو ار اس، بس الكيو ار اس جدا واضحه. اوكي الكيو ار اس موجودين. هلا الأونلي بروبلم بالكيو ار اس هي انه بيكونوا at irregular times. The reason for that انه لانه احنا في عنا disorganized stimulation للاتريا. هذا بيعني انه we don't know when there is a strong depolarization wave that can pass into the ventricles and excite them, creating a QRS complex. And because of that the QRS complexes are irregular. Okay? يعني بحالة الاتريال fibrillation الابنورماليتي الأولى اللي رح نشوفها إنه we don't have a P wave. There is no P wave. بس إنه اللاين هذا بده يكون wavy مش straight line. وبرضه ال QRS complexes موجودين but at irregular times. يعني we don't know exactly ما في pattern معين إلهم أصلا، ما في pattern. ما بقدر أحكي مثلا إنه بالأول بيكونوا خلال فترة very close together وبعدين they are further apart. We don't have any pattern لل QRS complexes. Okay, so this is atrial fibrillation. هلا على عكس ال ventricular fibrillation which is deadly, the atrial fibrillation يعني it's not a top emergency لأنه you know that when we lose coordinated atrial contraction we only lose about 30% of the blood that should enter the ventricles. يعني انتم بتعرفوا أصلا إنه ال atrial contraction يعني بدخل تقريبا 30% من البلد اللي لازم يدخل على ال ventricles only. The other 70% they enter once the AV valves are open. يعني it enters due to the difference in pressure. فبالتالي we're gonna lose this 30% only, which might not have a big effect. بس طبعا this condition needs treatment. هي الفكرة إنه it's not an emergency مش زي ventricular fibrillation, but it definitely needs treatment لأنه it can result in certain complications. ومن أهم complications اللي ممكن بتصاحب atrial fibrillations هو إنه نتيجة للستيسس اوف بلد، وانه دائما بضل في بلد جوا الاتريا، ممكن يبلش يتكون عنا ثرومبس داخل الاتريا، وليتر اون يعطونا امبولاي. اوكي، هذا بالنسبة للاتريال فيبريليشن. بيهمني جدا انكم تميزوا كيف الاتريال فيبريليشن ببين على الاي سي جي، وكيف الفنتريكولار فيبريليشن ببين على الاي سي جي. اوكي، طيب هلا بدنا نحكي عن الاتريال فلتر. هلا الاتريال فلتر يعني خلينا نحكي انه هو برضو عبارة عن ري انتري، هو ناتج من عملية الري انتري، بس الري انتري اللي بيصير بالاتريال فلتر مختلف شوي عن اللي بيصير بالاتريال فيبريليشن. انه بحالة الفلتر هذا الري انتري سيجنال بتكون هي نفسها and it goes over and over in a circular pathway. خليني أورجيكم إياها هون. هل هدول عبارة عن الاتريا. okay, this is the atria in case of atrial fibrillation and this is the atria in case of atrial flutter. هلا بحالة atrial fibrillation you can see إنه we have many signals and they are going in different directions, exciting different parts of the atria at different times, leading to the occurrence of atrial fibrillation. هلا بحالة atrial flutter it is the same signal. It goes over and over in the atria in a circular way, exciting the atria continuously. Okay, فبالتالي احنا هي signal واحدة but it doesn't die out. It continues to excite the atria over and over again. When we have multiple signals and they go in numerous directions, numerous times. Okay, هلا what happens in atrial flutter إنه because the atria are continuously being stimulated, the atrial rate is going to be very high. It's going to be around 300 beats per minute. The atria are going to contract at a rate of 300 beats per minute. Okay, هلا the ventricles on the other hand they cannot contract at this rate لأنه ال AV conduction يعني أو خلينا نحكي ال AV bundle cannot conduct all of these signals لأنه هي في إلها refractory period أكيد. فبالعادة إنه half of these signals pass into the ventricles، وبالعادة بيكون ال ventricular rate half the atrial rate. يعني إذا كان الاتريا they are contracting at a rate of 300 beats per minute, the ventricles they contract at a rate of 150 beats per minute بالعادة. أوكي، هذا هو الموست common اللي هو 2 to 1. So حكينا again سبب الاتريال فلتر هو الفينومينون of re-entry اللي هي نفسها سببت لنا الventricular fibrillation الاتريال fibrillation، بس الديفرنس هون انه هي it is the same signal, it goes over and over again, so it stimulates the atria at a very high rate. بالعادة it's around 300. The ventricles they are stimulated at a lower rate because not all of these signals can pass into the ventricles. The ventricular rate is around 150. So what are we gonna see on the ECG? هلا اللي رح نشوفه على ECG إنه we're gonna see very strong P waves، وهاي اللي بنسميها إحنا sawtooth appearance يعني زي أسنان المنشار. هيهم هون هدول they are P waves. Okay, they are very strong P waves. هلا لو بدنا نحسب ال atrial rate لازم نحسبه من خلال ال P waves. تمام، يعني ما بنحسبه من ال QRS complex، بدنا ناخد إنه high P wave و high P wave، شو ناخد ال distance between two P waves. هلا مثلا هون ال distance ما بيناتهم عبارة عن 1 large square، معناته ال heart rate عبارة عن أو ال atrial rate هو 300 divided by 1 large square which equals 300. معناته ال atrial rate is the 300 in this example. طيب الventricular rate كيف بدنا نحسبه؟ بدنا ناخد الديستانس between two R waves. هلا دائما انتم لما بتحسبوا الريت حاولوا انكم تلاقوا ويف تكون مثلا زي هاي exactly جاية على اللاين هذا اللي بفصل بين المربعات الكبيرة، وتاخدوا وحدة تانية بيكون كتير أسهل. هلا هون الآر في بيناتهم 1 2 3 4 مربعات كبيرة ومربع صغير واحد. اوكي، وبالتالي هون الفنتريكولار ريت رح يكون تقريبا 70 beat per minute. اوكي، حكينا دائما احنا انه الفنتريكولار ريت it's determined by the AV conduction. الكومنست هو انه يكون 2 to 1 وبالتالي بيعطيني ريت يكون 150، بس مش شرط، مش لازم انه يكون هيك. يعني هون تقريبا الريت هو 4 to 1، يعني لكل 4 P waves we have 1 QRS complex. اوكي، فإذا ممكن يكون 2 to 1 3 to 1 4 to 1 it depends actually على ال conduction from the AV node. So this is atrial flutter. Difference زي ما حكينا واضح جدا من هاي الصورة إنه in atrial fibrillation we have disorganized impulses going everywhere. Here we have the same impulse that it goes over and over again. Okay, exciting the atria continuously. So this is atrial flutter, and it's important to recognize it. إنه دائما we have strong P waves. We have an atrial rate that is very high. It's usually around 300. And we have a lower ventricular rate. الappearance اللي كتير هيك مميز له هو sawtooth appearance. إنه it looks like اللاين between the QRS complexes it looks like a sawtooth زي أسنان المنشار. أوكي، هلا رح نحكي عن موضوع آخر اللي هو الاتريو أو ventricular block أو ال AV block. Now you know إنه normally the only pathway through which the signal that's generated by the SA node can pass into the ventricles is the AV node and the AV bundle. Okay, now if there is a condition that delays the conduction through the AV bundle or block it entirely, this will lead to a condition we call atrioventricular block or AV block. Now the causes for AV block are multiple. It might be due to ischemia of the AV node or the AV bundle fibers, so they are no longer capable of conducting the signal. It might be due to compression of the AV bundle by a scar tissue or a calcified portion of the heart, thereby preventing the conduction through them or delaying the conduction at least. It might be due to inflammation in the AV node or the AV bundle, or it might be due to extreme stimulation of the heart by the vagus nerve. لأنه vagal stimulation it slows the conduction at the AV node and it might even block it completely. Okay, now بالنسبة لل AV block we have different types. We have the first degree heart block, second degree heart block, and third degree heart block. Second degree برضو له two types, type 1 and type 2, and we will discuss all of these types. And when we finish all of these, we're going to talk about the Stokes-Adams syndrome, which is يعني a variation from the third heart block or a type of third heart block. هلا first degree heart block, it is simply a prolonged PR interval. حكينا احنا انه في عنا certain limits لل PR interval. احنا بالعادة بنحكي انه اذا ال PR interval اكتر من 0.2 او 0.22 seconds then the PR interval is prolonged. Okay, it means that the signal takes a long time to reach the ventricles from the atria. And this is called first degree heart block. إذن شو هو first degree heart block؟ إنه ال PR interval is prolonged beyond ال 0.2 أو ال 0.22 seconds. Okay? هلا what we will see is a normal ECG strip that has one problem هي إنه ال PR interval is prolonged. بهذا المثال اللي عنا ال PR interval تقريبا 0.32, which means that it's prolonged, which means that this is first degree heart block. Now it might be caused by coronary artery disease, acute rheumatoid carditis, digoxin toxicity, electrolyte imbalances. Many causes can lead to decreased conductance from the atria to the ventricles. Okay, فهذا هو ال first degree heart block, prolonged PR interval. Okay. هلا second degree heart block هذا بيختلف شوي. بالsecond degree heart block ال prolongation بال PR interval بيكون أكبر، يعني كبير شوي. هو بالعادة بيكون بين 0.25 ل 0.45 second. يعني ال PR interval بتكون عبارة عن 0.25, 0.35, 0.45, something like that. هلا when the PR interval is this long, this will lead to a problem. إنه sometimes the depolarization wave can pass from the atria into the ventricles, leading to ventricular stimulation, and sometimes it fails to pass into the ventricles. It fails to stimulate the ventricles. فبهاي الحالة when it fails to pass into the ventricles, we call it a dropped beat. Dropped beat, okay? لأنه ما صار في عنا ventricular contraction. يعني إذا ال wave depolarization it didn't pass into the ventricles, then the ventricles won't be stimulated and they won't contract. Okay? هلا we said إنه there are two types, type 1 and type 2. Okay. هلا let's see the difference between type 1 and type 2. In type 1, and remember this is second degree heart block. In second degree heart block we have a prolonged PR interval that leads, sometimes the wave passes into the ventricles and sometimes it fails to pass. Okay, this is how we know that this is type 1, second degree heart block. هلا in type 1 of the second degree heart block we will see progressive lengthening of the PR interval until there is a wave that fails to be conducted. Okay, so if you look at this ECG strip, you will see that here the PR interval is 0.26 seconds. Then it becomes 0.28. Then it becomes 0.32. Okay, and then you will see a P wave with no QRS following it. Okay, so this is here a dropped beat. The P wave did not pass. طيب, after that what happens? The pattern will repeat itself. Now the next P wave, it has a PR interval of 0.26 seconds, then 0.28, then 0.32, then we have a P wave that doesn't pass. So there is a pattern and this pattern will repeat itself. There is progressive lengthening لل PR interval. PR interval عم بتزيد من بيت لبيت لحد ما نوصل لمرحلة إنه في عنا P wave with no QRS complex following it. Okay? So this is type 1. This is type 1 of the second degree heart block. هلا type 2 احيانا نسميه fixed ratio blocks. إنه there is a fixed number of non-conducted P waves for every QRS complex. يعني مثلا ممكن يكون في عنا إنه one P wave passes and one P wave does not pass. مثلا one is conducted and one is not conducted, أو one is conducted and then two are not conducted. One is conducted and then three are not conducted. عنا specific pattern. Okay, فهذا بنسميه احنا fixed ratio blocks. هلا على فرض إنه الباترن اللي موجود اللي هو زي هذا اللي هو احنا بنسميه 2 to 1, إنه one is conducted and one is not conducted. شو اللي رح نشوفه على ال ECG؟ رح نشوف something like this. إنه خلينا نشوفها. هلا هاي هون هاي عبارة عن P wave that is not conducted. okay? And then this P wave is conducted and it creates a QRS complex. Okay, في بعديها بيجي QRS complex. Then هون في عنا P wave that is not conducted and then a P wave that is conducted. فإذا بتلاحظوا أنتوا إنه كأنه بيكون الموضوع إنه for لكل 2 P waves في عنا 1 QRS complex، عشان هيك إحنا مسميه 2 to 1. يعني for لكل 2 P waves في عنا 1 QRS complex، لأنه 1 P wave is not conducted and then we have another one that is conducted. Okay, so it is 2 to 1. هلا لما نحكي إنه الباترن 3 to 1 معناته إنه في عنا 2 P waves. خلينا نرسمه هيك. لما نحكي إنه الباترن is 3 to 1 it means إنه we have a P wave that is not conducted, another P wave that is not conducted, and then a third P wave that is conducted and is followed by a QRS complex. فإذا لما نحكي 3 to 1 إنه we have 2 waves that are not conducted and then 1 is conducted. So it's like we have 3 P waves for every QRS complex. It is 3 to 1. So this is type 2. Okay. فإذا just to recap إنه first degree heart block إنه PR interval is prolonged. That's it. But every P wave is conducted into the ventricles. The only thing that's abnormal is a prolonged PR interval. In the second degree, we have 2 types. In type 1, we have progressive lengthening of the PR interval until a beat is not conducted, until a beat is dropped. Okay? In type 2, we have a fixed ratio. 1 conducted and 1 not conducted, or 2 not conducted and 1 is conducted. We have something fixed. But for sure, إنه في عنا some of the P waves can pass into the ventricles and stimulate it, others cannot. عشان هيك اسمه second degree. Okay. هلا نيجي على third degree heart block. Third degree is it occurs when the impulse fails to be transmitted from the atria to the ventricles. Yani there is complete blockage. None of the atrial signals can pass into the ventricles. In this case, what happens إنه ال SA node is functioning. It is stimulating the atria at a certain rate. Okay, but none of these signals can pass into the ventricles. So what will happen here? إنه the ventricles will establish their own signal. هلا وين هاي السيجنال رح تبلش؟ ممكن تبلش بالAV node، بالAV bundle أو بالPurkinje fibers. هلا أنتم بتعرفوا إنه هدول البارتس من excitatory system هم they can also يعني they can generate action potential on their own زيهم زي SA node، بس بالعادة الريت لإلهم أقل من الريت للSA node. يعني الSA node usually fires at a rate of 70 to 80 beats per minute. الAV node it can يعني fire at a rate of 40 to 60 per minute، بينما مثلا Purkinje الريت تبعهم بين 15 to 40 beats per minute. هلا usually لأنه ال SA node has the highest rate of firing, it is the pacemaker. Okay, so if the SA node is not working, إنه some other part might pick up. فبهاي الحالة إنه إذا في عنا blockage ال signal cannot pass، ممكن ال Purkinje fiber they take over، بس بهاي الحالة إنه رح يكون الريت لل depolarization أقل من الريت لل SA node. Okay, فبالتالي what we will see in third degree heart block هو كالآتي، إنه we have regular PP interval لأنه ال SA node is functioning normally. We have regular RR interval, but there is no relationship between the P waves and QRS complexes. يعني ال SA node is working on its own, it's stimulating the atria, and we have maybe the AV bundle or the Purkinje fibers, they are working on their own and they are stimulating the ventricles, the rate of ventricular stimulation is lower than the rate of atrial stimulation. Okay? هلا let's see this ECG strip. هلا هون زي ما انتم شايفين هون حاطين لنا arrows على أماكن وجود ال P waves. فال P waves they are equally distributed. They are equally distributed. ولو حسبنا ال atrial rate وبهاي الحالة بنحسبه من خلال ال PP interval رح يطلع تقريبا 90 beats per minute. اوكي هلا بالنسبة لل QRS complex هي هون لو أخذنا إحنا بين هاي ال QRS وهاي ال QRS وحسبنا الريت رح يطلع الريت تقريبا 36 beats per minute. اوكي هلا there is no relationship between ال P waves وال QRS complexes. ما في أي علاقة، يعني مثلا ما you cannot say إنه مثلا في عنا 2 P waves وبعديها QRS، لا، إنه هون مثلا في وحدة وبعدين QRS، وهون في عنا واحدة تنتين ثلاث وبعدين QRS، وبعدين عنا واحدة تنتين و QRS. ف there is no relationship whatsoever between ال P waves وال QRS complexes. ودائما الاتريال ريت بيكون أعلى من الفنتريكولار ريت. هلا ممكن نحكي كمان إنه ال QRS complex is abnormally shaped وبرضه it is prolonged. ليش؟ لأنه depolarization على الأغلب بدأ somewhere in the ventricles. أوكي فبالتالي ممكن مثلا يكون هذا ال stimulation بدأ بالرايت ventricle. الرايت ventricle was stimulated ahead of the left، فال QRS رح يطلع abnormal. okay طيب فإذا this is third degree heart block. إحنا بدأنا بالfirst degree إنه بس simply إنها PR interval is prolonged. second degree PR interval is prolonged بحيث إنه sometimes the signal does not pass. وبالthird degree اللي بيصير هو إنه none of the signals pass. فبالتالي إنه ventricles they have to create their own rhythm. They are on their own now. والرhythm يا إما بيجي من البندل و more commonly إنه يجي من ال Purkinje fibers. أوكي كيف بنميز هون؟ إنه زي ما حكينا ال P waves has no relationship to the QRS complexes وفي عنا two rates. ال atrial rate is much higher than the ventricular rate. Okay. Now Stokes-Adams syndrome هي actually third degree heart block, but this block comes and goes. It is not continuous all the time. Okay. هلا how long does the block continue? It is different. يعني from one person to another. وحتى بالنسبة لل same person it might be different from one time to the other. The block might last for a few seconds, a few minutes, few hours. Sometimes it might last for weeks. Okay. هلا اللي بيصير بالستوكس آدمز إنه the patient is normal, nothing is wrong, but sometimes he will have a third degree block. يعني signals that are starting in the SA node they don't pass into the ventricles. هلا what will happen إنه ال Purkinje system مثلا will pick up and will create its own rhythm. بس في عنا فترة زمنية اللي هي until إنه يصير في عنا ventricular stimulation. خلال هاي الفترة إنه ال ventricles will stop beating. ليش؟ لأنه بتعرفوا أنتوا إنه ال SA node هي ال pacemaker. صح ال Purkinje وال AV node عندهم القدرة إنهم يعملوا depolarization waves. They have autorhythmicity, but they are suppressed by the SA node. So they need some time to pick up. فبالتالي اللي بيصير بالستوكس آدمز إنه ال patient will be completely normal. ال ECG هيو completely normal. بعدين suddenly the block will happen. وبالتالي رح نشوف إنه ال ECG strip بس فيه P waves. There are no QRS complexes. طبعا during this time لما يكون عنا بس P waves هذا بيعني إنه ال ventricles they are not contracting. Okay, there's no pumping of blood. بالعادة ال patient will faint during this time. رح يغمى عليه لأنه there is no blood reaching the brain, okay? But soon after, within 5 to 30 seconds, إنه في عنا some parts of the ventricles will pick up, will start to produce its own rhythm. طبعا هون رح يصير عنا هاد لو كبرناه رح يطلع بيشبه الرhythm strip هاد، إنه في P waves في QRS complexes and they are not related to each other. فإذا الستوك آدمز هو عبارة عن third degree heart block but it comes and goes. بيجيكم المريض بيقولكم إنه I'm okay, يعني بالعادة إنه وضعي طبيعي but sometimes I faint. اوكي، فبهاي الحالة انتو طبعا لو بدكم تعملوا له ECG وهو ما عنده complaints ممكن يكون ال ECG completely normal. عشان هيك هدول المرضى بنعطيهم بنعمل لهم نوع من ال ECG اللي هو بيكون portable، يعني ال patient will take this device home، رح تعمل له ECG لمدة 24 أو 48 hours. بعدين بس يرجع على العيادة بتطلعوا الداتا من الجهاز هذا اللي اسمه الهولتر مونيتور، بيكون عامل ECG على مدى 24 أو 48 ساعة. ممكن خلال هاي الفترة إذا صار عند المريض الإبيسود إنه يبين عنا على ال ECG strip like this. okay. فهذا هو الستوكس آدمز، فهو عبارة عن variety من الثيرد degree. طيب هيك بنكون خلصنا احنا الاريثمياز اللي بدنا نحكي عنهم. حكينا عن الساينس تاكيكارديا، الساينس براديكارديا، الساينس اريثميا. We talked about the ventricular fibrillation, atrial fibrillation, atrial flutter، وبعدين we discussed the different types of AV blocks. هلا يعني خلينا بس هيك نحكي briefly عن some of the conditions that might cause axis deviation. هلا احنا حكينا المرة الماضية شرحنا كتير عن الأكسس. we said إنه إحنا في عنا normal axis، والnormal axis it varies between plus 90 to minus 30. If it is between minus 30 and minus 90, this is left axis deviation. If it is between plus 90 180, this is right axis deviation. And we have a variety which is called extreme axis variation. Extreme axis deviation, sorry, here between 180 and minus 90. هلا what might lead to an abnormal axis, to axis deviation? Okay, there are a number of conditions, including a change in the position of heart in the chest, hypertrophy of one ventricle, or bundle branch block. Now, we have some conditions that might cause left angulation of the heart. يعني الheart, this is the normal position of the heart. It is slightly angulated towards the left. Okay, but we have certain conditions that might increase this angulation like this. Okay, the angulation increases, and this might lead to left axis deviation. Okay, these conditions include deep expiration, lying down, والobesity. طبعا كل هدول الconditions they increase the angulation لأنه يعني it's almost the same reason. إنه diaphragm is gonna push the heart, okay, and it will increase its angulation towards the left. فممكن إنه شخص يكون طبيعي 100%، بس إنه مثلا على ال ECG يبين إنه كأنه عنده left axis deviation، لأنه مثلا لحظة ما عملنا ال ECG كان عم يعمل deep expiration مثلا، أو he was lying down. احنا حكينا دائما ال ECG when we do it لازم يكون المريض يعني نايم على التخت بزاوية 45 تقريبا، يعني at least بين 30 وال 45. If he lies flat ممكن يبين كأنه عنده left axis deviation. Why? Because the heart becomes angulated within the chest. Okay. هلا we have conditions that cause right angulation of the heart. يعني the heart will become angulated towards the right. It includes a deep inspiration and standing up. Okay, standing up. When you stand up, the heart will most probably be more angulated toward the right. هلا دائما أو في كتير من الناس خصوصا التول thin people the heart will be angulated towards the right. يعني ممكن هدول يكون عندهم right axis deviation مع أنهم they are completely normal. السبب إنه heart will be angulated towards the right. هلا في عنا pathological conditions that can lead to axis deviation including hypertrophy of one of the ventricles. هلا لو على سبيل المثال إنه الشخص صار عنده hypertrophy بالليفت ventricle، بهاي الحالة most probably إنه البيشنت رح يصير عنده على ال ECG left axis deviation. أوكي، بينما إذا صار عنده hypertrophy بالرايت ventricle most probably إنه رح يصير عنده right axis deviation. هلا why does this happen؟ هلا if the left ventricle is greatly hypertrophied it means that more muscle mass exists on the left. هلا انتم بتعرفوا انه موضوع الاكسس بيحددوا انه المسل ماس كل ما كانت المسل ماس اكبر بيكون لها تأثير اكبر على الاكسس. اوكي، لانه most of the electricity will come from the hypertrophied part. يعني إذا left hypertrophied it means it will contribute to the cardiac axis more than the right. This will lead to left axis deviation. Also one of the reasons for this shift is that when one of the ventricles is hypertrophied it means that it would need more time to be depolarized. Okay, it means that the normal ventricle will be depolarized in advance. هلا هذا شو تأثيره؟ خلينا نيجي هون مثلا على فرض إنه this is the ventricle. Okay, هيك this is the septum. If the left is hypertrophied it means إنه depolarization here is gonna be delayed. Okay, it's gonna be delayed. It means إنه right will become negative. sorry هلا هذا هون في عنا خلينا نحكي left hypertrophy like this. left ventricular hypertrophy, this part is hypertrophied بينما right is not hypertrophied. It means إنه the right will depolarize first. It will become negative while the left is still positively charged. Most of it is positively charged. This means إنه the vector will go towards the left even more than normal. يعني هو normally it should be like this. هلا it will be like this. بالإضافة زي ما حكينا إنه هون في عنا more muscle mass, so it will contribute to the depolarization vector more than the right. For these reasons, when one ventricle is hypertrophied, the axis will be deviated towards the hypertrophied part. فإذا left ventricular hypertrophy على الأغلب رح نشوف معه left axis deviation. right ventricular hypertrophy رح نشوف معه right axis deviation. أوكي. السبب الآخر لل axis deviation هو ال bundle branch block. شو يعني bundle branch block؟ هلا لو إجينا هون usually signal that reaches through the AV bundle will pass into right or left bundle branches at almost the same time. يعني هي it enters the left slightly faster. يعني الموضوع مش كتير واضح slightly faster. لكن إذا في عنا bundle branch block يعني زي هون في عنا left bundle branch block, it means إنه signal cannot enter the left bundle branch. It only enters the right. It only enters the right bundle. What does this mean? It means إنه the signal will enter through the right bundle. It will stimulate the right ventricle, leading to the depolarization of the right ventricle. Okay. Now the signal will, left ventricle will be depolarized through the right ventricle. يعني the muscles or the cardiac muscles that are found in the right will transmit the signal to the left ventricle. But this transmission is gonna be relatively slow. يعني مش زي لما يمر من خلال البندل. It will be relatively slow. That's why إنه the right ventricle will depolarize ahead of the left ventricle. يعني this will be negatively charged while this is still positively charged. فهذا رح يعمل لي الأكسس يكون deviated towards the left. العكس بيصير بالرايت bundle branch. بالرايت bundle الرايت is blocked وبالتالي السيجنال is gonna go faster into the left. It will stimulate the left and depolarize it, and then the signal will be transmitted from muscle to muscle into the right ventricle. So the left ventricle will depolarize ahead of the right, leading to right axis deviation. هلا برضو لأنه ال depolarization للventricles does not happen at the same time exactly سواء بحالة الهايبرتروفي أو البندل برانش بلوك رح نلاحظ إنه ال QRS complex is widened. هلا إحنا حكينا بالماضي إنه ليش ال QRS complex الديوريشن له قليلة جدا لأنه بالعادة both of the ventricles are stimulated at the same time. هلا إذا صار الستيميوليشن not at the same time في variation بالتايم رح يكون ال QRS complex is wide وهذا الإفكت أوضح بحالة البندل برانش بلوك يعني الديلي بيكون أكبر منه بحالة الهايبرتروفي. فإذا موضوع الأكسس ديفيشن إنه if it is there it doesn't always mean that there is something wrong with the patient. Sometimes it is due to زي ما حكينا هون إنه مثلا change in the position of the heart in the chest due to مثلا expiration or inspiration, lying down or standing up, being obese or thin. Axis deviation by itself ممكن it means nothing, but if you find axis deviation in an ECG you should look for other abnormalities on the ECG that might indicate that there is something wrong with the patient. يعني مثلا زي ما حكينا بحالة البندل برانش بلوك والventricular hypertrophy ممكن برضو يكون في عنا widened QRS complex. برضو في عنا abnormalities تانية but I'm not going to talk about them now. So you should know once you find an axis deviation you should look for other abnormalities to specify if this is يعني a benign condition or it is associated with some abnormality. Okay, I think this is the last thing that we will talk about, which is the ECG changes that we can see in myocardial infarction and in angina pectoris. Now, you know the difference between myocardial infarction and angina pectoris. Angina, it is simply ischemia of the cardiac tissue. يعني when we have decreased the blood supply to a certain part of the heart, this will lead to angina. This will lead, the patient will present with pain, okay, with chest pain. But this pain comes and goes in most types of angina طبعا. You know, it comes and goes. Sometimes the patient will complain of chest pain, and this is due to decreased blood supply to the cardiac tissue. هلا myocardial infarction is different. In myocardial infarction, we have decreased blood supply that will lead to death of the tissues. Parts of the heart, يعني part of the cardiac tissue is gonna die. It's gonna infarct. Okay. وبالعادة مريض المyocardial infarction complains of severe pain that is persistent, that lasts for longer than 30 minutes. ففي عندنا differences طبعا بالpresentation. يعني المريض اللي عنده MI بيجي يشكي من severe pain, من sweating, البين بيكون ممكن longer than 30 minutes, it has lasted for longer than 30 minutes. بينما بالانجينا بيجي المريض بيشكي من chest pain that comes and goes. Okay. هلا برضو على ال ECG في changes that will help us in the diagnosis of myocardial infarction and angina. Okay. هلا بحالة المyocardial infarction one of the earliest signs هي the occurrence of ST segment changes. يعني ST segment depression or elevation. This is one of the earliest changes. وبالعادة هاي ال ST segment changes it happens in certain leads, not in all the leads, حسب ال part of the heart that is affected by the infarction. يعني إذا كان مثلا infarction بالlateral wall, yes, بالlateral wall of the heart, mostly اللي رح يكونوا affected leads اللي ممكن يكون فيهم ST segment changes هم lead AVL 1 V5 و V6. هدول most commonly affected بحالة إنه إذا كان abnormality أو infarction عم بتصير بالlateral wall. هلا if the infarction is happening in the inferior wall of the heart, the leads that will be affected that will show ST changes are leads 2, 3 and AVF. Okay? Now leads 1, 2 and sometimes lead 3 are affected in cases of anterior wall infarction. Anterior wall infarction. So one of the earliest signs that the patient has an MI is ST changes on the ECG. Okay? And we said previously that to be considered significant, we must have more than 1 millimeter of ST segment elevation or depression in 2 lymph leads, or 2 millimeter of ST segment elevation or depression in 2 chest leads. الشرط الآخر إنه هدول الليدز يكونوا contiguous leads، يعني they look at the heart from the same side. يعني مثلا زي ما حكينا بالinferior wall مثلا 2 و 3 و AVF. هلا إذا شفنا ST segment depression مثلا بليد AVF وليد AVL، حتى لو كان أكثر من 1 مليمتر it is not significant، لأنه they look at the heart from different views. يعني they look at different parts of the heart. This looks at the inferior wall, this looks at the lateral wall. Okay? So they have to be 2 leads that look at the same wall of the heart. Okay, so in case of myocardial infarction, the earliest signs are ST segment changes. هلا later on هدول ال ST segment changes they will reverse. ال ST segment بالعادة returns to baseline after a day or 2. يعني these are not permanent changes. Okay, but في عنا other signs هدول ممكن يصيروا later on، اللي هو إنه ممكن يصير في عنا T-wave inversion و development ل pathological Q waves. أوكي، وبالعادة هاي changes خصوصاً ل Q waves، ال pathological Q wave بتكون permanent changes. فإذا ال MI خلينا نتذكر إنه ال earliest signs هي ST segment changes and these changes are not permanent, they will reverse. هلا later on ممكن يصير في عنا inversion ل T waves و development ل pathological Q waves. هدول changes خصوصا ل Q waves they are usually permanent. If they happen they will stay there. Okay. هلا بحالة الأنجينا أكتر شيء ممكن نشوف فيها هي ST segment changes، يعني depression أو elevation. بس الفكرة إنه هدول changes they are seen only when the patient is having pain. يعني once the pain has resolved ال ECG returns to normal. فممكن المريض إذا إجا مثلا كان complaining of chest pain، وبالعادة هذا chest pain مثلا بيكون during خلينا نحكي الستريس أو during الإكسرسايز، هو بالعادة إذا بدل أي مجهود ممكن يبلش عنده chest pain. إذا إجا على العيادة وكان he is not in pain وعملنا له ECG، على الأغلب ال ECG رح يطلع normal. عشان هيك هدول المرضى اللي عندهم أنجينا بينعمل لهم something called stress ECG. بالstress ECG what we do إنه we make the patient exercise على treadmill and then we perform ال ECG. فبالتالي إذا هو عنده أنجينا فعلا رح نلاحظ إنه رح يصير في عنده ST segment changes. أوكي، فإذا خلينا نعرف إحنا إنه بحالة الأنجينا والأم آي في عنا changes mostly على ال ST segment. أوكي، ومش كل ال ST segments بيكونوا involved حسب ال wall اللي involved. وبحالة ال MI إنه ال ST segment changes are not permanent، بس ال T wave inversion وال Q wave ال pathological Q it might be permanent. بحالة الأنجينا إنه ال ECG changes are noticed only while the patient is in pain, and that's why sometimes we have to do the stress ECG. Okay. هلا هذا مثال على ST segment depression in unstable angina. هلا وين شايفين إحنا ST segment depression؟ إحنا شايفينه ب يعني في موجود ب V2 بس أوضح كتير ب V3 V4 وبرضه V5. أوكي، ففي عنا 3 leads V3 V4 V5 هدول كلهم they have depression لل ST segment. أوكي، يعني هذا المريض إنه في عنده unstable angina. هلا otherwise ال ECG is normal، في عندهم sinus rhythm rate is 60 normal axis normal QRS، just إنه في عنا ST segment depression in leads V3 to V5. برضو في عنا يعني مبينة شوي ب V2 بس هي أوضح بهدول الثلاثة leads. أوكي، هلا هون هذا مثال على exercise induced ischemic changes. يعني إجا عنا مريض على العيادة بيشكي إنه sometimes he has chest pain. We performed this ECG and it was completely normal. Nothing is wrong. Okay. هلا when we performed the stress ECG يعني we asked him to go on the treadmill exercise and then we did this ECG. اللي بتلاحظينه هون إنه صار عنده ST segment depression. أوكي، شوفوا هون هاي هون ST segment it is depressed. أوكي، طبعا الهارت ريت زاد صار 125 per minute as opposed to 55 نتيجة للإكسرسايز طبعا. أوكي، نتيجة للإكسرسايز زاد الهارت ريت، بس مش هاي هي المشكلة إنه صار في عنده ST segment depression. أوكي، طبعا هم هون بس مورجينا ليد وحدة بس إنه أكيد يعني بيكون هذا الإفكت it was evident in more than one lead. أوكي، هون في عنا مثلا ST segment elevation it is found in V1 in V2 V3 V4 يعني شوي برضو ب V5. all of these leads they show ST segment elevation. فهذا دليل إنه في عنا something wrong. ممكن يكون ischemia ممكن يكون infarction إنه في something wrong leading to these ST segment changes. Okay. طيب هلا we said the term pathological Q waves earlier. pathological Q waves. هلا pathological Q waves هم عبارة عن changes on the ECG, permanent changes that indicate that there was a prior injury to the cardiac muscle يعني prior myocardial infarction. أحيانا بنشوفها إحنا while the myocardial infarction is happening but usually it's يعني it's very evident after some time. هلا to be considered pathological هلا بتعرفوا انتوا ال Q هي ال first negative deflection بال QRS complex. Okay. هلا to consider the Q wave pathological it has to have a duration of more than 0.04 seconds. It has to be more than 2 millimeter deep or it has to يعني be more than 25% of the depth of the QRS complex. هلا this figure shows pathological Q waves in leads V1, V2, V3 and V4 also it can be considered pathological. Halla, this is the QRS complex and you can see that the Q wave it is more than 2 millimeters deep. Okay, so this is definitely pathological Q. It indicates that this patient might have myocardial infarction previously. Okay. So we have discussed all of the abnormalities that I was planning to discuss with you. Now, the last part of these slides shows some abnormal ECGs. Okay, I want you to look at these ECGs carefully. And when I meet with you over Teams, maybe next week or the week after that, we will discuss these abnormal ECGs, but have a look at them, try to figure out what's wrong with these ECGs, and we will discuss them, inshallah, during our live session. Okay, best of luck. Bye-bye.